Elliot Kaminetzky is a licensed clinical psychologist and the founder and director of My OCD Care in New York City. He specializes in the treatment of OCD or obsessive-compulsive disorder and other anxiety-based disorders. In his practice, he uses a variety of treatments, including acceptance and commitment therapy, enhanced response exposure therapy, and parent-child interaction therapy. We welcome Dr. Kaminetzky to be talking with us today. As a clinical psychologist, can you give us the DSM classification of what anxiety and obsessive-compulsive disorder is? Can OCD accompany other disorders such as depression?
Okay, great question. So OCD is an anxiety-based disorder, right? And I think sometimes people could get lost in the weeds of the DSM. And some of the distinction between the disorders and even the categories are a little arbitrary. But OCD and anxiety disorders are officially in separate categories. There's like the anxiety disorders and the obsessive and compulsive related spectrum disorders. Within the anxiety disorders, you'll have specific phobia, generalized anxiety disorder, panic disorder. And in the obsessive compulsive spectrum disorders, you have obsessive compulsive and related disorders. You'll have OCD, you'll have trichotillomania, which is a body-focused repetitive behavior where you pull your hair, as well as hoarding disorder. So even though OCD is an anxiety-based disorder, it's in its own category since the most recent DSM. So anxiety, is an emotion that everyone feels, right? It's an emotion that's related to preparation for a possible negative event, and it's what keeps us safe, right? Like our ability to prepare for negative future events, like really keeps us around. It prepares us. It helps us plan. When anxiety becomes a disorder is when this emotion that's been to help us is actually working against us, right? So such as when we're getting signals of anxiety, even in the absence of danger, right? Even in the absence of things that you actually need to prepare for. And because of being in that constant state, maybe you engage in a lot of avoidance and you don't do things that are, very necessary, such as, feeling too anxious to go in public transportation, let's say. And that could get in the way of you living your life, doing your work, being in relationships, friendships, so that's when it becomes an anxiety disorder. And OCD has a similar characteristic in that you have intrusive thoughts, right, which, cause a lot of distress, anxious distress. These thoughts can be, what if I forgot to, shut off the stove, right? And you'll kind of get these repetitive intrusive thoughts called obsessions. And, when we're in distress, we engage in compulsions, which are behaviors meant to reduce that distress, right? And that is a repetitive behavior or a mental behavior that we do to reduce that distress. And that can be repetitive. And that really gets you stuck in that cycle. And it's a disorder because it's not something that's helpful. And it's something that's really painful and gets in the way of you living the life you want to live.
Right. So there are coexisting comorbid conditions that accompany OCD. So that's definitely something to always look out for.
Yes, absolutely. The part of the question I didn't address. So depression is a common co-occurring one. And I believe the statistic is like 60% of individuals with OCD have had a major depressive episode. Sometimes it's secondary to the OCD, like someone with OCD who may lose their job because of their OCD, or may lose relationships because of the OCD, and they'll find that, suddenly they're feeling very, very depressed. Even if it's not full-blown depression, low self-esteem is very common in individuals with OCD. Other anxiety disorders, such as generalized anxiety disorder and panic disorder, are very common with OCD. Trichotillomania, or body-focused repetitive behaviors, are common in individuals with OCD. So just because you have OCD doesn't mean it's the only disorder you'll have. And when you're with a very good professional, they'll kind of really take into account everything you're experiencing and make a very detailed plan, that prioritizes what we're going to work on, what are the commonalities between these disorders, and how we could, really address them all in the most efficient way possible.
Yeah, no, for sure. So for people who are not exactly aware of what OCD is, many people have false theories on the disorder. Can you elaborate on what OCD is and what it is not, in terms of, we went through the definition you mentioned about OCD just now, so maybe go into what OCD is not?
Yes, absolutely. And I think this is something that's fairly bothersome to the OCD community of professionals and individuals with the disorder, is kind of that saying of like, oh, I'm so OCD. So there are like there's the errors that have to do with trivializing the disorder, which is kind of saying things like, I'm so OCD, meaning I'm just so neat, right? And this person could, obviously it could very well, and probably most of the time not meaning any harm, but I think because they kind of make it into almost like a quirk of being someone who's very neat, people suffering with the disorder will say like, I can't have OCD, even though they're having like intrusive thoughts of, harming someone, right? These really scary intrusive thoughts all the time, and they're doing, various mental rituals to address it, and they have really bad OCD, but they won't even know it because, people just think it has to do with cleaning, right? So that's like one of the most common misunderstandings. There are even like cleaning services with the name OCD in it, so, and like, you wouldn't have that, people wouldn't use, cancer for marketing, and people who are really suffering with this disorder, like, are hearing it trivialized, and it's, very challenging for them. So it's definitely not that, and it's not just washing hands, for, fear of dirt or germs, even though that could be, individuals with OCD sometimes do have that presentation. It's just not limited to that, right? And it's also not just like a quirk, like a personality quirk where someone is, maybe obstinate or needs things to be a certain way, right? That could just be a personality quirk on the one end. On the other end of the spectrum, it could be obsessive-compulsive personality disorder, where you have like this, really challenges with rigidity, and also, unhelpful levels of perfection, right? So I think those are the important things of what OCD is not.
Okay. Those are great points.
Thank you.
We spoke a little bit about this, but what are the common symptoms that OCD presents? We can go further into besides intrusive thoughts. And then when should a person be evaluated for OCD?
Okay, great question. So OCD, like, have your obsessions, right? Intrusive images, impulses, urges, intrusive thoughts, right? That are repetitive, unwanted, right? And no matter like what you try, it seems like they just keep coming back, even if you try not to think about it. And then you have repetitive behaviors called compulsions that are like an unsuccessful attempt at reducing the anxiety that's associated with those obsessions, which creates that OCD cycle that's so hard to break, right? And that really could be, translate into tremendous suffering, right? When people just either don't know what's going on, or don't know how to address it, right? So I think like the time, like anyone who is having sensitivity to their thoughts, and because of that, it's hurting their quality of life, I don't think you need a full-blown diagnosis to get help, right? I think if you're feeling a lot of anxiety and that's interfering with your life, you know, if you're finding that you're ruminating, right, that means like you're kind of, let's say, just worrying a lot about a particular issue and it doesn't even seem effective. You're just like keep on regurgitating, you know, the same issue again and again and again, and it feels like you can't stop. That's a very kind of, that's a compulsive behavior that is important to learn skills how to not do. So I think if you're really, if your quality of life is suffering, I think it's time to speak to someone, right? And I don't think you need to wait for it to become bad before you address it, because you could have some really helpful tools that you could use, you know, if it were to become, you know, really problematic. So I think like you don't need to have like an exact just like name of a disorder to get help. I think you really want to speak to someone who's specializes in, you know, anxiety and OCD if you're even feeling that.
And when you say somebody that specializes in OCD and anxiety, of course, therapists, psychologists like yourself, but when should also maybe somebody see a psychiatrist for medication? Like, who would be the first step that you would refer, or first person you would refer somebody, or you would tell somebody to go to a psychiatrist
Absolutely.
or psychologist?
So, according to the American Psychiatric Association, the first line treatment for OCD would be exposure and response prevention, which is a type of cognitive behavioral therapy. That could be done by psychiatrists who are trained in it. It could be done by psychologists, clinical social workers. It could be even students who are under the, you know, students of psychology who are under the supervision of a specialized, of a specialist who knows how to deliver the treatment. But in terms of, you know, where you start, I think when you're able to engage in the treatment and the treatment is available to you, you know, even the American Psychiatric Association would recommend starting with exposure therapy and seeing if medication is necessary. If the OCD is so severe that you know, engaging in treatment doesn't even seem like someone is even willing to do, then they would recommend, you know, starting with medication. These could be SSRIs, selective serotonin reuptake inhibitors, aka antidepressants, or tricyclics like clomipramine. And there are a number of other drugs, medications that are used for OCD, sometimes in conjunction with behavioral therapy, exposure and response prevention, sometimes as a standalone treatment, and it's just helpful. There are some new treatments on the horizon, you know, that are still being developed for severe treatment refractory cases. These include TMS, like transcranial magnetic stimulation, which is still being investigated further, but it has, I believe, been approved by the FDA for use in OCD.
Oh, that's great. I hope that, is that a treatment that's people are starting to use now since it's been FDA approved?
It's becoming more popular, and I think they're still investigating it. And I think it, you know, it wouldn't be the first line treatment. I think it would usually probably come after exposure therapy and medication hasn't worked. They would consider using this. And there's also different, using TMS, and there's also different levels of care, which could be appropriate depending on the level of severity of an individual's OCD, right? So there is, you know, classic once a week treatment, you know, potentially for an hour a week, and then people could have multiple sessions per week. And then there is, you know, called an IOP, which is partial hospitalization. Oh, intensive outpatient is IOP. And there are places that you could get more intense treatment, and then there's residential settings such as McLean, in Boston, that is really a full-time program of both exposure, and I believe they do medications as well.
Okay. So we talked about how with OCD you have obsessive thoughts, compulsions, hence the term OCD.
Mm-hmm.
Why, and maybe we have to go, or you have to mention the biological underpinnings, but why are these thoughts and compulsions so debilitating for a person who has the disorder?
Okay. So why are they? So I think, first of all, imagine having the scariest thought playing in the back and the front of your head for hours and hours every day. Mm-hmm. So when you're having that, could you really focus very well on the work you need to do, or the relationships in your life, mm-hmm. or the fun things you want to do? Like, it's extremely difficult. Also, the compulsions that people engage in could range from interfering with your life to even dangerous. There are individuals who have the OCD pertaining to contamination, mm-hmm. and will, put chemicals in their body, when, let's say, wiping to make it, disinfect it, mm-hmm. and, they could cause damage to themselves. But there's the issue of, let's say people are engaged in compulsive checking for hours every day, mm-hmm. and, you have to fit the rest of your life around the compulsions, right? Mm-hmm. And the more compulsions that you're doing, you are, in fact, lending credence to the intrusive thoughts, right? Because your body kind of takes a message from the behaviors that you're doing that, hey, like, I am doing all these behaviors. There must be a true danger, right? Or else why would I be doing all of this compulsive behaviors, right? And it becomes very almost like addicting to do these mm-hmm. compulsions, because it, only when I do these compulsions do I feel any sense of relief, even if it's so brief, but that's the only way I'll feel relief. And it's very hard to break out of that, and, mm-hmm. fitting your life in around the OCD versus, just living your life mm-hmm. is really how it can be so disruptive.
Yeah. So you manage, you specialize in the practice, you specialize in your practice specifically with the treatment of, or the technique of, acceptance and commitment therapy, enhanced approach to provide exposure response prevention to patients. Can you give us a brief overview of what that technique is?
Sure. So acceptance and commitment therapy is a treatment probably from the 90s, started by Dr. Steve Hayes, who I actually interviewed, and he's quite an awesome character. And yeah, so it is a treatment that's part of the third wave behavioral therapies, which are categorized based in mindfulness, which is all the rage these days, but it's actually a really helpful technique in helping people be present, be aware, be in the moment that they're in, rather being stuck in your head, and also being able to be flexible with your attention, right? And because it's a mindfulness-based therapy, mindfulness is an extremely powerful tool when it comes to, intrusive thoughts, because, right, we are, instead of just being stuck to our thoughts, we're able to kind of take a step back and look at our thoughts and look at what are helpful ways to deal with these thoughts and what are unhelpful ways, right? And when you're ruminating, sometimes you could be like, hey, I've just been ruminating about something for the past 2 hours and I've just been sitting here, right? So just developing the awareness of what you're thinking, what's a helpful use of your mental time, that is mindfulness right there. Also, it's a value base, right? So it's acceptance and commitment therapy. So you accept whatever you need to accept in your life and commit your life to what's truly valuable to you. And that builds psychological flexibility, right? I know I'm throwing out a lot of terms, but it really gives you a great lexicon of tools and concepts to use in fighting the OCD very effectively. So psychological flexibility is I'm not going to wait until I feel great in order to live the life I want to live. I'm going to live the life I want to live. And some days I'll feel better, and some days I'll feel worse. But I'm going to develop the flexibility that it doesn't matter so much. And what matters is me committing to the life that I want, right?
Mm-hmm.
And that goes with acceptance, right? And commitment.
Mm-hmm.
And that's the therapy.
Okay, sounds good. And do you, I know you have experience also in cognitive behavioral therapy. Do you practice any cognitive behavioral therapy with these other techniques?
So I think cognitive behavioral therapy is like the umbrella term, which includes ACT and includes exposure and response prevention. It's like really just therapies that deal with the way we think, deal with the way we behave, right? And working towards building a better life, using those tools and the interaction between how we think, we behave, how like our emotions, like these are all dealt with and kind of customized to the particular disorder, right? So like with OCD, we're not really challenging these thoughts because which is a CBT technique potentially used for other disorders like depression or generalized anxiety, which you wouldn't necessarily use for OCD because it just doesn't work. So under the framework of CBT is exposure and response prevention, which probably leans more towards behavioral in terms of really focusing on both educating on what OCD is and how to really break that cycle using our behaviors to act not in accordance with the intrusive thoughts.
Yeah, that makes sense. So you also specialize and are one of the few clinicians to provide parent-child interaction therapy, which focuses on helping parents and caregivers implement treatments with their children. Can you elaborate on this technique and what the benefits are of this technique?
Yes, absolutely. It's actually one of my favorite therapies to do. And it's actually PCIT, parent-child interaction therapy, is a therapy to help children with oppositional defiance disorder. And PCIT CALM, right, is the adaptation for anxiety disorders, right? And it basically belongs to a category of treatments which empower parents to really be the therapist, right? Because like if you think about therapy, it's just such a tiny slice of the week, right? Like let's say you're getting an hour a week of therapy, just one hour of a full week is just such a tiny slice, and for it to have influence could be challenging. So in CBT, we're always talking about doing homework, so you can really bring what you learn in the session to the rest of your life. But like kids, don't always love doing homework, right? I don't know, maybe you can relate. I certainly can.
I can, for sure.
Yeah, so it like helps the parent be the therapist and helps, help them give positive attention instead of giving attention to negative behaviors like searching for the good, and also being very consistent. Another behavior, another treatment, alongside of PCIT and PCIT CALM, which is the anxiety disorder version of PCIT, is SPACE, which is supportive parenting for anxious childhood emotions, which is a treatment that treats childhood anxiety without even working with the children. It's just working with the parents and really helping the parents remove the accommodations they're doing for their children's anxiety. So sometimes parents with children with anxiety disorders will be doing things like, classic example, if a kid has social anxiety, they'll talk to their friends for them, right? They'll answer, like if a waiter comes and asks, oh, what do you want? What do you want to order?
Mhm.
Like the child will be silent and the mother will, or father will explain, we'll just tell the waiter what he's having, right? That's an example of a parental accommodation of anxiety. And they found, and it's an evidence-based treatment, that simply by removing the accommodation, right, the parental patterns of accommodation, that really helps the child's anxiety disorder. So basically, PCIT, CALM, and SPACE are really helpful treatments for kids that really empower parents to be the therapist.
There's a lot of misconceptions about OCD, as we spoke about, and many people always worry when they have the disorder or a parent of a child who's newly diagnosed, will they be able to live a quality of life with OCD?
Yeah, great question. I will say unequivocally that you could have OCD and still live an amazing life. The biggest tragedy of OCD is when people don't know what it is and they don't get help, and because of that they're unable to live the life that they can live, that they want to live. And you see so many individuals, both therapists and patients in the OCD community, who are doing amazing things, right? Upon recovering from OCD, even if they still are struggling, they're taking their pain and they're making it into meaning, right? And they're doing, great things. And it ties back with values, how really the ticket out of OCD and so much pain in life is to figure out what I want my life, what do I want it to look like? What do I want to be known for? Right? Like, what is bigger than the pains that I experience? And whether that's depression, intrusive thoughts, anxiety, like when we're able to overcome that adversity, it can make us, so much stronger, right? And everyone's struggling with something, right? Like really, everyone's struggling with something, and OCD can be a tremendous challenge. But I found that there is such amazingly strong individuals, and when they work on OCD, like their potential becomes unlocked, right? Like what they're really capable of, and you see them doing amazing things, right? And sometimes a lot of them are suffering in silence, like they're doing amazing things and you would never know they have OCD, because they just bottle it up and they keep it so locked in. But when you speak to them, like, you learn that they're suffering so much, so even if you're already living your life to the fullest, you could still be having a really challenging time. So with treatment, you don't have to suffer like that.
Yeah, absolutely. So what advice would you give to someone who has OCD and is struggling, or a parent or caregiver who has a child or a family member with OCD?
Okay, so I guess number one would be get help, right? And get the right help, right? And also be part of a community, right? I think, just like the organization that you found, Different Enable, did I get that right?
Yeah.
Like, it's very helpful to know that you're not alone, right? And there are really helpful, peer support specialists, Chrissy Hodges being one of them, who has experience with the disorder and also has recovered from the disorder. And it can be really, really helpful to be a part of that community. There's a ton of resources at the International OCD Foundation at iocdf.org, where you could get a ton of information about OCD and hear information from professionals. And there's also a therapist directory. They don't vet the individuals on the directory, but you would need to do your own research. But you want to get someone who is a respected provider in the OCD community. And I think you want to get help, and you want to get the right help. And you don't want to work with a jack of all trades and who happens to treat everything, and anything that, you happen to have is something that they treat. Like, you want someone who demonstrates that they've dedicated their career to treating this disorder, because it's not something that's necessarily intuitive on how to treat it. Right?
Yeah, definitely. So now we have the questions from our community.
Okay.
All right. All your points were great.
Oh, thank you.
As to be expected. I'm not surprised. Okay. Do you have any advice for a parent or caregiver of a 32-year-old daughter with very severe OCD? She's housebound and unable to look after her own basic needs. She refuses to engage with a doctor or psychologist. Any advice?
Well, it sounds like it's like a very severe case.
Mm-hmm.
If she is an adult and she refuses to engage in treatment, that is her right.
Mm-hmm.
However, it's also the parent's right to decide that they're not going to accommodate that
Mm-hmm.
anxiety. And I think even the parents could get help. Like, they might even benefit from space, to learn how they're potentially accommodating this anxiety and ways to reduce that accommodation.
Mm-hmm.
But, I think, just to reiterate, you can't force anyone into treatment if they're not ready.
Right.
But the question is, you could determine how much you are willing to enable,
Mm-hmm.
her not getting help, right? Like,
Mm-hmm.
if they're just staying in the home, right, and
Mm-hmm.
they're getting all of their needs met, right, and they're just doing compulsions all day, right, then that's kind of like enabling them not to get help because they're getting everything they need.
Right.
So space therapy has a lot of good techniques for situations like this.
Okay. All right. Anyways, those are all our questions. So thank you so much.
Yeah, my pleasure.